I would speak a few words on ECMO, newer indications and future. There are no financial support. Whatever I don't do is a newer indication for me. Whatever I don't have is a future for me. Everyone is at a different level of hierarchy and aspirations, and in different circumstances of economics and opportunities. So there are success and failure, and there has been a zone from 1975 then to 1990, then 2000 to 2010, and then 2020 and beyond. So we are in a stage of progress and transition. Each one is in a different time zone. So the future for ECMO is different for everyone. Pediatric population is getting stabilized. We are getting more adults patient. There are new population and other challenges related to circuitry, the staff, and the adult physicians. First of all, looking at our country, I feel the hardware is the first aspiration that we would like to have to give a better results. Whenever I used to go to conferences in the Western Hemisphere, I used to uh, really feel sad that why did I buy that machine last year? This machine is better this year, but I cannot purchase each machine, any machine every year. So there are many developments that they become a future for me. That when sometime I will replace my older machine with the newer features of the new machine. So all these hardware like the monitoring of the ECMO circuits, the peripheral monitoring, the microaxial pumps, the stealth tubings, the pumpless ECMO circuits, various consoles, better anticoagulation, nitric oxide applications, various catheters, easy cannulations, and pre-primed circuits are just a future for me because still till date we are hardly having 25% of the inventory. These are just a few figures of the thing hardware I just mentioned. Details I cannot complete on them, but they become an indication for me to get them and use it. So these are the improvements that other improvement in the technology, that no permanent bridge, better bladder, reduced surface contact of the blood, reduced priming volumes, increased speed, and ECPR with the pre-primed circuits and newer circuits and older circuits. The comparison of decrease in the extra corpuscular volumes, they become the future for me. So improved blood material interface, ideal circuit, improved anticoagulation and portability with non-thrombogenic endotheliums like this, using of other anticoagulation materials other than heparin, which are still sometimes very difficult to be uh, procured in the times of requirement. So various type of surfing coating materials, we- and the advantage of those surfing coating materials, effect of nitric oxide on platelet, the endothelizations process, which makes the newer materials safe and more effective on the patient, various type of cannulas, that various type of configuration of the circuit of the cannulas, the DLC cannula, the Avalon cannula, the catheter placements, and introduction of newer companies coming out with better products. They are all a future for us because we don't really have them available in India. Other devices, the carbon dioxide therapy treatment will be covered in subsequent lectures in the same session. But other extracorporeal techniques of AVC2R, Nova lung, ILA, and the ambulatory lung, all these things are again part of our future for us because we only read them in slides. We really don't get to see them. So these things are there, they are costly and not available in India. So these were just the process of development from animal studies till the time they become practically applicable to human population. So these are all the the newer developments which have taken place in last 2 decades, and they are in future for us. So other combinations and nanotechnology to make artificial structures is also a goal for us. So therefore, a new extracorporeal technique in terms of devices, in terms of technique, in terms of patient selection, and available in other markets are again a future for us. What Bartlett did 5 years ago is a future for us. So this is all just what you saw, what is available and we don't have is time distinct time lag, but it will sooner or later we will be reaching that. Other indications, what I say, we don't talk of few very remote indications. I look ECMO as a ventilator, and I look ECMO as a ventricular assist device. If you think that whatever are the problems with the ventilator, and you can go and get away with 2 lines and reduce the effect of the ventilator on the patient, then the indication of ECMO is tremendous. How many patients of a patient on ventilator, if they get replaced by a very effective and a economical ECMO circuit, then look at the application of ECMO in future. ECMO as a mechanical circulatory support or ventricular assist device. I feel that as a cardiologist in 2000, I have been struggling right from my registrarship days, patient of cardiogenic shock with dying before me, and I am helplessly just doing CPR. There was no option. After getting out through angioplasties and bypass also, it was a big vacuum that I do not have anything to offer them for survival. Then in 2006, from 2000 onwards, at least I had 4 or 5 interactions with Alan Coombs, and I was asking him, will ECMO help in cardiogenic shock? Because that was my biggest interest. And he also was not able to give me a satisfactory answer. Subsequently, in his later talks, he admits that ECMO is becoming the first line therapy as a ventricular assist device. So over the time, you look at the population of cardiogenic shock and myocardial infarction in India, and you will realize that if ECMO becomes the first line therapy in cardiogenic shock, look at the future of ECMO in India. ECMO has AVC2R, ECMO has ambulatory artificial lung, ECMO in transplant, ECMO in organ transplant, organ transplant, ECMO in transport, medical applications of ECMO in poisoning and post bone marrow transplant, sepsis and thermotherapy, and surgical ECMO. These are all the future of ECMO. This is one of the famous pictures which everybody quotes. This is to show the staff nurse at US, UK opted for ECMO rather than ventilator, just to because she had seen the comfort with ECMO rather than going on ventilator. ECMO is gradually gaining hold to become a peripheral VAD of cardiogenic shock with poor LV in for cardiac cases. Other main application for ECMO that is coming up is extracorporeal interval support for organ retrieval. That is the use for a donor by cardiac death. The extracorporeal support for organ transplant is a very good indication. The ischemic preconditioning of donors of cardiac death followed by reperfusion of fully oxygenated blood, gradual cooling and reduction of metabolic activity, and crystalloid flush and final cooling to metabolically inactive stage is the process by which we preserve the organ in a better condition. And we find the functioning of the organs improves from 31% to 66%, and the rejection is much less. This is the circuit, or this is the component required for organ support in organ transplant, ECMO supported organ transplant. The outcome has been phenomenal. It is for all the in all aspect, the outcomes has been good. So ECMO has increased the numbers of donors by 30%. Organ functioning after transplant was much better than from donors of cardiac death. This is just few pictures of how to apply ECMO for a donor of cardiac death for organ preservation. You see the vascularity of all the organs and how it is being preserved. Then another application is the thermotherapy, that wrapped therapy, in which an ECMO circuit would achieve the same thing at least 5 times faster and in a much better way. And you don't require any special circuit for it. You only require the blood to be cooled outside, and it is much more effective. So the warming technique is as a process. Normally, normothermia can be achieved in 30 to 45 minutes, and you continue with the regular uh, treatment of the patient and maintain the coagulation factors after the warming the patient. Then elective ECMO for complex tracheal reconstructions, complex bronchial repairs, cardiac shunting procedures, complex bronchoalveolar lavages, and uh, it can be done with less heparinization because it's a surgical procedure and something similar to VV ECMO. So the elective use for tracheal reconstructions, it provides an excellent environment. It allows resting of the airways. It's the viable option in the management of complex tracheal stenosis. These are few of the pictures. This is how it is being shown, and this is the effect of this was the lung before and the lung afterwards on ECMO. So then coming more thinking of more ahead, what Robert Bartlett quoted this in 2017, that other than in translational research, that ECMO has to be applied to future things like looking at the clinical problems of artificial implantable lung, which is taking shape, artificial placenta and organ bank. Organ bank also is now started coming up. Artificial placenta is still in the animal stage, animal experimental stage. So again, this is telling artificial ambulatory lung and the artificial heart, if they become slightly more convenient and less complex, but then the indications are too much to deal with. This is the applications of ECMO as an artificial placenta, still in experimental stages. Organ banks for organ preservation. This should be coming up, but this is the future of ECMO. So the take-home message is that don't give up. Each one of us are on a different platform. Rome was not built in a day. Short, steady, shuffling steps to your goal would find a much brighter future of ECMO for you in future. Now, this was just to show you a documentary. Not only great things, I would say routine things is also a future for us. Many allied speaker in all the conferences has been talking about ECMO, the future of ECMO in routine processes. So I would just like to show you some of the screenshot of the slides at different conferences where they were all talking about the applications of ECMO in future and the future trends. So this is what ECMO getting popular in refractory cardiogenic shock, ECMO getting higher up in the guidelines for the ECS and guidelines, then ECMO getting more popular in acute myocardial infarction, and the survival benefit increasing up to 36% and 42%, which was less than 20%. And later studies showing that the population of acute myocardial infarction patient to around 51% in these trials. ECMO in fulminant myocarditis, long-term survival being excellent. ECMO in complicated cardiac surgeries, ECMO after heart transplant, ECMO in cases of massive pulmonary emboli, ECMO after cardiac arrest, ECMO after septic shock and severe LV failure. ECMO, VA ECMO is best because it is short and it is economical. And the various trials, mobile ECMO rescue tubes, and application of IABP with ECMO, because in India, the only additional mechanical circulatory support available here is IABP. Though people have criticized a lot of IABP with shocks and that ICS trial, but then I would like to say it works. It works for the time. You can think about something not beneficial after 1 month, but if the patient has to live that hour, the IBP will work. So IBP and ECMO is perhaps what is available to us. So it is effective, and we need to have more experienced by applying more patients of cardiogenic shock on ECMO, because that is the diabetes and myocardial infarction is the biggest health burden of a population. So these have been all discussed and taken in trials, and the results have come. They are also a future for us. Everybody of us is not a scientist, but in clinical practice also our common problems should be repeatedly reassessed. Then LVS ECMO is a part of LVSS device, and ECMO is now the first line device. The results of ECMO after ECPR is better in in-hospital cardiac arrest. The result of ECMO with pulmonary edema uh, as compared to other devices is what Alan Coombe has to quote of his lifelong efforts of ECMO applications in all these conditions. Then Thomas Muller has also started quoting on the various conditions in which VA ECMO can be applied, and the better results as compared to the previous decade. So that is the future. We have to keep on trying to improve the results. That is VA of VA ECMO or any ECMO in the difficult scenarios. So then again, Euler trial was a good efforts, but that is what is science is, which shows that everything will not be rosy or it will be fruitful. But then ECMO for acute respiratory distress syndrome, which has already proved its efficacy. There's no controversy on that. Then the same results being published about the Euler trial. Then Robert Bartlett has classified the progress of ECMO from 1965 to 2005. Then the from 2005 to 2008. So ECMO one era was 1975 to 2008, but it was too complex. It had a lot of uh, 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 difficult issues, and there were less success. Then technical improvement took place and came the ECMO 2 phase from 2008 onwards, in which better circuits, better experience, uh, new population of adult getting added, and new different class of population of consultants contributing to the knowledge of ECMO, improve the results of ECMO in the various arenas. Then this is how the various circuits have also improved, which gave us more ideas and more fields to work on. So this is about what Robert Bartlett has to say. Then James Fortenberry has a different aspect of future of ECMO. He's worried about the education and research. He says that the steering committee, the education, the non-profit organization, the ELSO registry, the ELSO website, the Red Book, ELSO education, ELSO future possibilities, increasing collaboration, promoting ECMO, increasing adult participation, global ECMO. That was his way of promoting ECMO as a future. Then Steve Conrad, I don't understand it at all. He's so complex. He has come up with so many new things I have only heard for the first time. The novel approaches of support of ARDS. So he's come up with components of making the circuit within the inferior vena cava. There are devices which the carbon dioxide exchange, the oxygen transport. There are filters within the length of the IVC, and he has put the ECMO inside the body. This is the work still going on. Patent has already been achieved, and these are the figures where he shows that ECMO can be miniaturized. There are other chemical ways of making it a miniature form in vivo by intravenous oxygen, microbubble physics, nanoscale manufacturing and printing, and respirosite design. I don't understand it, but he was talking about micro manufactured capillaries and capillary oxygen transfer and all those things. So something is the application of ECMO and the future of ECMO is phenomenal. Then our Sunil Puvani sir, he was always worried about the future of SWAC also. So he has written articles on past, present, and future, and the future is bright, he says. Then as you see the runs of ECMO as being an adult physician, urgent population physician, VV ECMO and VA ECMO in the present arena is 90% of the total ECMO runs. So that also gives an encouragement that ECMO has a great role to play. Then in the COVID era and other pandemics, the registry has helped us in a big way. So maintaining a registry and data is also a future because it helps everyone. So this is I wanted to say. Thank you very much.